My name is Matthew Smith and I've been asked to talk about MRI scanning with hearing implants in situ, and in particular to give the patient experience and the complications that can occur during scanning with the magnet in situ. Now, there are two types of implants that are commonly encountered, certainly here in Manchester, and these are a cochlear implant where there is an external speech processor and coil which transmits through the skin to an implanted receiver stimulator package which sits below the hair, below the scalp. And the electrode for that passes through the temporal bone, through the middle ear, and into the cochlea to stimulate the cochlea directly. There are other types of implants. The auditory brainstem implant has a very similar stimulator receiver package, but the electrode does not go to the cochlea. It bypasses the cochlear nerve, and is therefore useful in people who have injury to these two areas or dysfunction. And it sits on the brainstem and stimulates that directly. And there are other devices that have similar magnet-containing subcutaneous receiver stimulator packages, such as middle ear implants that might vibrate structures within the middle ear or within the mastoid bone. And all of them have similar issues with MRI. The magnet is the key here, and that sits some way away from the ear, and that will be easy to locate using the external removable magnet to point you to it. And it's that magnet that comes under considerable forces during MRI scanning. Now, this is some work from a few years ago looking at magnets, not in people, but measured in a controlled environment. And you can see that the torque on the magnet is greatest towards the center of an MRI scanner. And the distance to the isocenter is there on the x-axis. And you can see that within 50 centimeters or so of the center, there is a very high torque reading, and that falls off relatively rapidly as you approach the bore, the exit of the bore, and then pass out of the scanner. And actually the forces that are horizontal to the magnet, so not rotating forces, but forces that are pushing and pulling the magnet around, are actually greatest at the end of the bore, so at the opening of the bore. And you can see that on the right there. The distance to the isocenter again is on the x-axis and the force on the y-axis. And actually the force applied to the magnet and therefore the implant is greatest at the opening, because that's where the magnetic gradient is at its greatest. Now, there are various problems that patients experience with MRI scanning when you scan them with an implant and the magnet in situ. And probably the most noticeable for the patient is pain. And actually some patients have very, very severe pain. Some have no pain. And if you look at the literature, there's variable visual analog score readings, with 0 being no pain, 10 being very extreme pain. And actually the readings come out in the region of 0 to 3.9. And that probably depends on the type of scan the patients are having and the type of device that's been used in that study. But you can see there that a lot of patients are going to have moderate or severe amounts of pain during scanning. And actually in some cases it's so unbearable that it prevents the patients being scanned. Now, mostly this pain just happens at the time of scan. There might be a slight bruised feeling afterwards. It doesn't normally persist after the patient's left the scanner and several days later. And the other complications can be due to magnet movement. Now, the magnets can dislocate from the silicone housing, or they can flip over so that the alternative face is facing outwards to the skin. And in a conventional magnet, that means a reversal of the north-south pole, which means that the coil doesn't stick to the skin over the scalp anymore, and instead it's repelled. And actually magnet complications have been described in up to 15% of patient scans in some series, and they're usually associated with severe pain due to stretching of the soft tissues around the area. And if a patient does have a dislocation of the magnet, then they will have to have a local anaesthetic for that to be replaced, which of course is not very pleasant for the patient and does introduce a significant risk of infection to the implant, which can be catastrophic, requiring explantation. For those patients where the magnet flips, sometimes we can reverse it on the coil, but it doesn't always work. And the other issues that are discussed are demagnetization and device damage, either through electrical current generation or heating, or loss of the poles on the magnet. And actually this is probably very infrequent, and it was a problem with earlier devices but isn't so recognized anymore. So I was asked to talk about the Manchester data that we've got, and there's been data collected in Manchester prospectively from 2010, and we've got complete data set until 2018. And here you can see the number of patients who've got an ABI, an auditory brainstem implant, and the number who've got a cochlear implant. And this is the number of performed scans with different devices. The MED-EL devices are divided into synchrony and other devices for reasons that will become clear. And cochlear and advanced bionics are other manufacturers. And you can see the scan duration there, typically 20 to 30 minutes, and the areas that are being scanned. And the ABI patients have a high proportion of scans of areas beyond the head and cervical spine, and that's because a lot of them have to have surveillance scans of the whole spine. Now, in Manchester, we use two different techniques in most of our patients who've got a cochlear implant in to enable us to scan them with the magnet in situ. And you'll have heard about these in the other talks within this series. So I'm not going to go into any details, but the basic is the basic intervention is that we wrap the head tightly with a bandage, and in many patients we'll use local anaesthetic, whether that's lignocaine, bupivacaine, or xylocaine, and that's just injected around the subcutaneous receiver stimulator package. So this is our prospectively collected pain data, and this is using a visual analog score where the bottom of the pain score is a 1, which is no pain, and 5 represents extreme pain. And the error bars here are the standard deviation. And you can see that at baseline, some of our patients do have pain from their implants, but most of them do not. And then once you apply the bandage, actually the pain scores do go up considerably, and that is a statistically significant difference. And that's because the bandages we apply are quite tight. They have to be to try to reduce the risk of magnet complications, but they are uncomfortable, either just due to tightness around the head or pressure over the magnet itself or the device itself. And actually during scanning, possibly because we bandage them so tightly, that eliminates a lot of the movement of the magnet and a lot of the forces, and therefore the pain during scanning isn't actually any greater than it is with a bandage alone. And the scores for bandage patients and during scanning are just above 2, so it's a mild to moderate pain. Now, we've had 8 adverse events in our series of 183 patients who were bandaged, so that's 4.4% of those scans, and 4 of those were magnet flipping events and 4 were magnet dislocations. And it's worth noticing that the magnet dislocation events were all in patients who'd previously had the magnet removed for scanning purposes, probably therefore weakening the implant housing. So it's been well recognised for a very long time that the MRI scans are problematic in patients who've got cochlear implants, whether it's due to pain or complications, and indeed earlier implants were completely contraindicated for a complete contraindication for scanning. The cochlear implant device companies have therefore come up with some clever ideas for eliminating a lot of the pain and complications that have been seen. And so now there are many implants where you don't need to bandage the head and you don't need to use any local anaesthetic. And the different approaches that have been taken for this are shown here. So the company Advanced Bionics has developed a magnet that's relatively complex, containing multiple magnets that are able to roll within a housing to align to the ambient magnetic field and also rotate around an axis. So there's this whole 3D movement allowing the magnets to completely align within a scanner. Medel and Cochlear, which isn't shown, have changed their magnet design. So instead of having the north and south pole on opposite faces of the magnet, they now have developed a diametral magnet that is able to rotate within its housing, again to align itself to the magnetic field around it. And then on the bottom right of the screen, you can see the Oticon solution, which is a more rigid housing that you screw to the underlying skull, and the magnet's held within this, and that should eliminate movement of the magnet and the pain that patients experience, which is probably due to stretching of the periosteum and the surrounding tissues. So how do these things affect our patients' pain? And this is again Manchester data. This is actually all scans that we've had in the last, between 2010 and 2018. So it's 227 scans. And we were looking for associations of variables with the baseline pain and the scanning pain. And this is the baseline pain you can see first of all. So this is the age of the patient at the time of the scan, the implant device grouped by manufacturer with Medel devices. The Synchrony device is one of those ones that is MRI compatible with a rotating magnet. The other Medel devices don't have that. Implant type, CI versus brainstem implant, the area of the body scanned, and the duration of the scan. And at baseline, there is none of those variables show any relationship with the baseline pain. During scanning, actually, we do see that different devices have different degrees of pain during the scan. And for the area of the body scanned, again, we see a difference in the pain that patients experience. And so to look at the way that those variables affect pain, you can see this plot here, which shows the interacting relationship of the area scanned and the type of device. And you can see that the cochlear devices are associated with a greater amount of pain. Medel devices that are non-MRI compatible have a slightly less degree of pain. And the Medel Synchrony devices with the rotating magnets have the lowest level of pain, which doesn't really deviate from the baseline at all. And the patients who are having their head and C-spine scanned tend to have lower degrees of pain than those who are having other areas of the body scanned. And that probably makes sense when you consider the initial slides that we saw with those two graphs taken in a laboratory study, where the horizontal and other forces on the magnet, so not the torque forces, but the other forces, were all greatest towards the edge of the bore as the patient's going in and out of the scanner. And that's where the head will spend a lot of the time if you are scanning the full spine, for example. And that's probably why those patients have greater degrees of pain. So what about the patients who have the head wrap group? So looking back again at those who are wrapped tightly, what are the relevant variables for that group? Taking out of the equation the Medel Synchrony device and putting into this list of variables local anaesthetic to see if that is of any help, because we only gave local anaesthetic to the patients who had the head wraps. Well, you can see again at baseline that there were no differences in variables, no difference in pain with any of those variables. Again, implant device makes a difference, and that will be the Cochlear versus the Medel non-synchrony devices, which we've already seen are different to each other. Local anaesthetic, however, doesn't seem to make a difference to patients' pain. And that's interesting because obviously we're injecting these patients to try and reduce their pain. And we had a group of patients who chose not to have local anaesthetic. They weren't necessarily the ones who'd had scans before that weren't painful. And we probably had some patients who weren't offered local anaesthetic. And actually, they didn't have higher pain scores than those who did have anaesthetic. It's very difficult to draw conclusions from that because these were not randomly assigned treatments and they were self-selecting patients, really. But it is interesting, and it has influenced the way we pre-consent our patients about a local anaesthetic. So what's a summary of our findings? Well, newer devices simplify MRI scanning. You don't have to wrap the heads. You don't have to inject local anaesthetic, and the patients don't complain of significant pain. Tight head bandaging is our preference in Manchester, and as you'll have seen from previous talks, we use a moulded cover over the top of the implant to improve its stability and to apply more even pressure. We don't always use local anaesthetic, and probably with our recent analysis, we'll start to give patients more the option of this, explaining the lack of good evidence for benefit. And when it comes to pre-scan counselling and consent, it is really important that patients are consented to the risks and to the fact that they might have considerable pain. And in particular, it's important to tell the patients that as they move into the scanner, they may have significant pain, but that won't necessarily persist as their head moves closer to the centre. And therefore they should not panic and feel that the scan needs to be abandoned. It's also worth explaining to patients that if they are having a scan of a limb or a whole spine, they may experience more pain than if they were just having their head as well, alone. But overall, our experience is, in common with other groups, that MRI scanning with the implant magnet in situ is safe and very well tolerated by our patients.